Good afternoon. Let me present the latest data you can find in literature on bifurcation. This is my potential conflict of interest. So this is what I found, the numbers, more than 130 papers in between October 2019 and October 2020, mostly related to the stenting technique, novel devices and clinical outcomes, but also to bench models, imaging and complications and the case reports. There are three important studies I will not discuss now because they will be discussed in detail later in this conference. So let me start with a bench study performed by Gabor Toff and colleagues when they investigated the new qload stenting technique, double kissing qload, and compared with decay crush and regular qload. So that's the principle of this technique. Basically, you perform final kissing inflation twice after each rewiring. So what they found was that the duration of decay qload was significantly lower as compared to decay crush technique. On the micro CT analysis, they found that the decay qload changed the side branch angulation significantly less as compared to decay crush. And also they found on the OCT analysis some signal of improvement in terms of better stand apposition, at least in some part of bifurcation like proximal May branch or the roof of the polygon of confluence. So they concluded that double kissing approach can significantly facilitate the performance of the qload technique, and decay qload may be superior not only to conventional qload but also to decay crush technique, which of course has to be confirmed in a clinical study. So this is a great anatomical paper when the authors investigated the anatomical attributes of clinically relevant diagonal branches by using MPI and computer tomography. So what they found was that myocardial territory supplied by the diagonal branch is determined mostly by the circumflex dominance and also by number of branches and the dominance among the diagonal branches. So you can appreciate on the right-hand side that if you have a single occluded diagonal branch and there is no circumflex dominance, then the ischemia will be more than 50% of myocardial mass. Whereas if the same single diagonal is occluded, but there is a dominance of circumflex with a large obtuse marginal branch or intermediate branch, then the ischemic region will be much less than 10%. So not every diagonal branch, not every side branch is clinically important. This is the study checking the different stenting technique, investigating what stenting technique is the best for complex bifurcation lesion, just a network meta-analysis, 26 randomized studies included. And the answer is already in the title. So what the authors found was that decay crush, as compared to other technique, is clinically beneficial to the patient. They found a significant reduction in device-oriented clinical events, which was also confirmed by this Bayesian random effect model. So they concluded that in the management of true coronary bifurcation lesion with a two-stent technique, when a two-stent technique is required as an upfront strategy, the decay crush perhaps will be the best and should be preferred. Now, two interesting papers trying to ask the question of the significance of kissing inflation. The first one coming from Excel study with long-term 4-year observation. As far as for the one-stent strategy, no big surprise that they did not find any significant impact of final kissing balloon on the outcomes. For two-stent technique, I think that's the surprise. They didn't find any advantage of performing kissing, which may be presented by those two Kaplan-Meier curves. So if you look at the left-hand side, there is a single stent strategy. You can observe even some harm by kissing, whereas on the right-hand side, two-stent technique, there may be some advantage which was not statistically significant in the study. So the authors conclude that routine final kissing balloon inflation may be not necessary after left main bifurcation PCI if an acceptable procedural result is achieved. Now is a question, what is acceptable result and how we should measure it. Another study touching the same question, the impact of kissing balloon stenting. This is the study with modern generation stents reported by a RAIN cardio group, more than 2,500 patients. And what they found was generally the same as for the provisional, for the single stent strategy, no significant difference as compared to the outcome. But for the complex two-stent technique, you can appreciate a clear, significant improvement in MACE, mostly driven by reduction in TVR or TLR, which may be also very nicely presented by those Kaplan-Meier curves. The COBIS-3 study, the Korean multi-center registry, more than 2,600 of patients included. And this paper was designed to answer what is the outcome if different stenting strategies are applied for left main and non-left main bifurcations with current generation drug-eluting stent. And what they found was that for left main bifurcation stenting, one stent strategy is beneficial for the patient. So there was a clear benefit if only one stent was used, and mostly driven by target lesion revascularization. No difference as for cardiovascular death or myocardial infarction. Yet for non-left main bifurcation stenting, the authors found no difference. So no significant difference, neither for cardiac death, myocardial infarction, nor for target lesion revascularization. But this study has a couple of limitations. We have to keep them all in mind that this is non-randomized, retrospective, observational, and the patients with two-stent strategy were more likely to have a complex lesion profiles than those with only one stent. So this is obvious, and we all should keep in mind. And finally, just a glimpse in some imaging studies. The first data come from the Nobel long-term observation of patients with left main stented with IVUS or without IVUS guidelines. Generally, no big difference between the groups, apart from the TLR. So the use of IVUS at the end of the procedure resulted in a bigger minimum stent area and the reduction of target lesion revascularization. Another study with a big number of patients, more than 11,000, and the data come from the British Cardiovascular Interventional Society database, and they found that in an unprotected left main stenting, the use of IVUS reduced significantly mortality, and what is really interesting is that this benefit was observed very early in hospital phase, but also after 30 days and 12 years. And another great study showing that IVUS is important for the left main stenting, but this study shows that not the IVUS as such, but when you use an IVUS, you should know what you're looking for and what kind of criteria you should meet with this technique. So the authors first developed this optimization criteria, and then they try to follow them. And what they found was that not only just the pure use of IVUS, but just the meeting of those criteria, they call it IVUS Pro Group, was the prerequisite of obtaining better results for mortality and for left main target lesion revascularization. And this is my last slide, only 8 minutes, so it's not enough to analyze a lot of interesting studies. Just to encourage you to read this paper published by our Asian colleagues with some help of Jens on coronary bifurcation interventions, the Asian view, as well as a great paper, a white paper by European Bifurcation Club on stenting techniques, beautifully illustrated, very practical, and very useful in our daily practice. Thank you very much for your attention.